So we're going to walk through some data for two of the pairs, Medicaid and Blue Cross, based on the episode design we just discussed. As a note, the time frame for this data for Medicaid, Arkansas Medicaid, it's the calendar year 2010, and for Blue Cross Blue Shield it is from July 2011 through June 2012. So if you flip to the next page here, this is the basic cost structure of a colonoscopy episode. This first page is for Arkansas Medicaid. So you can see that a colonoscopy with additional procedures on average is about $1,270. Without additional procedures is about $1,000. And you can see also on this page the breakdown between the different types of costs. So 5 to 6% on average is the inpatient facility fee. About 50 to 60% on average is the outpatient facility fee. The professional fee is about a quarter of the overall cost, and pharmacy is about 13 to 14%. This is the cost structure for Medicaid. If you flip with me to the following page, you'll see the same chart or set of charts, but for Arkansas Blue Cross. And you'll notice also there's now also a diagnostic colonoscopy listed here with additional procedures. And the splits are a little different. The outpatient facility is between 30 to 45%, and the professional fee is anywhere between 45 to 55% of the overall total cost of the episode on average. Again, I'll walk through some of these and then invite questions and comments as well. On the following few pages, what we have here, this is very similar to the charts earlier in the discussion that Dr. Golden showed, but this is with real data for colonoscopies. So on page 31, what you see here is first for Medicaid. These are for colonoscopies with additional procedures. Here's the cost variation in the state today. Every single one of the bars is an individual physician that is performing a colonoscopy. So you do see some variation here in the average cost of the episodes. These charts already take into account all the different exclusions and clinical factors that we discussed earlier. Those are already all accounted for in the data. So this is a subset of episodes that are still valid, so to speak, and that's what you see the data for here. You'll also notice the number of providers. For Medicaid, for colonoscopies with additional procedures, there are 134 physicians that performed the procedure. 66 of those had at least 5 Medicaid cases. You'll see in a little bit those 66 providers accounted for the majority of the volume. The following page is the exact same analysis, but this is for colonoscopies without additional procedures. So you do see a little bit more variation, a little bit more of a spike on the left-hand side there. And there are 60 performing providers for Medicaid that had at least 5 of these episodes. The following pages there are 3 of these for Blue Cross for the 3 different types of episodes. There's a diagnostic colonoscopy with additional procedures. Because again, same sort of chart that you see here with 138 providers that have had at least 5 episodes. The page after that is the same thing, but for screening colonoscopies that had additional procedures with the modifiers that Matt mentioned before. So you can see what this variation looks like. And finally, the third of these pages on the following page is, again, for Blue Cross. This is page 35 now. Screening colonoscopies without any modifiers, without any additional procedures on those modifiers. This is the cost variation for Blue Cross. And there are 80 performing providers that had at least 5 Blue Cross episodes during this time period. In terms of how the volume is concentrated across various providers, if you look with me to page 36, this is for Medicaid. What you see here is how the volume is split across different PAPs in the state for Medicaid. So the first bar there is, you'll see it's actually behind Dr. Murphy's head, 163 there. Those are the 163 Medicaid providers that performed a colonoscopy for Medicaid. That's 100% of, you'll see each of these bars represents the number of episodes per provider. So what you see is 15% of 15% of episodes were performed by providers that less than 5 bucket that had less than 5 episodes that would not be participating in the upside downside gain or risk sharing in this. And that's 96 providers that basically, so 96 providers had very few episodes. 67 providers had 85% of the volume in the state for Medicaid on colonoscopies, and you can see how that breaks down across the different volumes across providers. So the following page, same thing for Blue Cross. You'll see 184 providers. Yes, this page right here. No, this. Yeah, thank you. They've rated that dark shaded bucket. Providers that had at least 5 Blue Cross Blue Shield colonoscopy episodes. There were 184 of those. And they accounted together for 98% of the total volume for Blue Cross Blue Shield during this time period. Okay, and then I will show two more analyses here, and then pause for again discussion. On page 38, yes, this page right here for Medicaid, this shows the rate of full sedation across different performing providers. So you'll see each one of the clunks on this chart is the category of what the rate of full sedation is for a set of providers. So in the 0 bucket, you'll see that for Medicaid, there were, in the dark blue bar, there were 40 providers in the state that had a full sedation rate across all their episodes of 0%. And that set of 40 providers represented 72% of all of Medicaid's episodes during the year. You'll see on the right-hand side, for example, in the 81 to 100 bucket, so 9 providers that had at least 5 episodes, that's the dark blue, had a full sedation rate of at least 80%, and those providers represented about 15% of the total episodes in the state. So you can see kind of where the distribution is. There's some folks on the right-hand side and some folks on the left. Is there a question or a comment right here?
It's a question.
Yep.
When you say full sedation, do you mean the provider himself providing it or having anesthesia available?
It's if the patient had full sedation. So for these, there would be an anesthesia involved, anesthesiologist involved. Yes.
Different from conscious sedation.
And the final page here, if you go to the next one, is the same chart, full sedation utilization, but this is for Blue Cross. So same chart, so 78 providers had a 0% full sedation rate, accounting for 27% of total episodes. 36 providers had an 80 to 100% full sedation rate, accounting for about a quarter of episodes.
Quick semantic question.
Sure.
Why are you using the term full sedation rather than deep sedation?
Well, I think propofol is, is complete. You're completely under, and requires a different set of monitoring as opposed to conscious sedation. So I think that's what we're capturing. And
Joe, can you?
No, I'm trying to figure out. Clearly, conscious sedation. The terms that we would use, and I believe that the terms that come from the anesthesia literature are conscious sedation versus. In fact, there's also light sedation. There's light sedation, conscious sedation, and deep sedation. And you're right; they have very different implications.
Right.
When we can check the terminology, I'll ask my wife when I get home.
Okay.
Regardless of what the label says, and you can help us,
Yeah.
the chart is based on just episodes or patients that where propofol was used.
We have clinicians here who have privileges and do use propofol, non-anesthesia administered, so gastroenterologist administered propofol. And while there's some debate, right? So
Right.
That may have a small impact in pharmacy costs, though the amounts tend to be pretty negligible, but doesn't have anything to do with. I'm just trying to figure out are those people going to be picked up in this situation?
They will be not. So because this is based on claims data, the input they received was that if it's a propofol use, more than likely there will be an anesthesiologist involved. So the way we did it is that on the day of the procedure, if there's also an anesthesiology professional fee that's attached to the procedure, then we assume that it's for sedation. But
So I implore you to change that terminology and say anesthesiologist involved with case.
Got it. Okay.
That's a great
And
point of feedback.
there are times in which we may have an anesthesiologist involved with a case, even if the level of sedation is not particularly deep. For instance, a patient with mental retardation who simply can't participate
Sure.
with the case.
Yeah, that's
So that's a different issue, and
Yep.
I think you're making an assumption by changing the terminology, and you don't need to do that.
Yeah, thank you for that feedback. That's very helpful.
So is the propofol going to become a quality metric, or is this driving towards a cost metric, or why was propofol even mentioned?
Not many gastroenterologists are not credentialed to use propofol. You can get the credentialing, but it's now being used. It's now deeper sedation. Is that the right term? Requires a different set of credentialing in facilities to use it, at least on a patient safety standpoint. The question then comes up about appropriate utilization of that and the extra costs. In a fee-for-service world, it's just costs added on costs, everybody gets paid. In an episode-based approach, people might start questioning to themselves, when do I want to use that modality? When don't I want to use that modality? It's not a quality metric, but it is a potential marker for a higher cost episode, which it's up to the site to decide whether that's how they want to manage the episode for each case.
And just to ask the more specific question, on the page you see here with the distribution, again, this is just meant to facilitate discussion. I see some providers that are much more on the left-hand side with a much lower use of an anesthesiologist versus others that are on the right-hand side with a very different usage pattern. And so the question is, what's leading to that? And I'd be interested for folks in the room or on the different sites if you guys have any thoughts on what explains
Bottom
that.
line, it's a practice variation that has cost implications.
Well,
Carter?
on our side, it's a surgeon, general surgeon, who does GI procedures, and so therefore she doesn't do the credentialing for anesthesia procedures. So we have CRNAs that come in, so it's MAC. And I'm not sure that they're necessarily using propofol. So say it's just an anesthesia charge, is that going to kick into this? Or is it just strictly the propofol charge you're looking at?
No, it is the total cost of care. So if you have anesthesia charges in your episode on a regular basis and your peers do not, there is a practice variation.
That's for your rural facilities. For staffing purposes, that may be an issue for a rural facility. I don't know about other facilities that are small, but where the outpatient procedure is done in the OR suite, where there's a GI suite, not a separate lab, or an outpatient surgical center, and there's limited staff, the CRNAs help cover that. And so that might be an issue, but we can look at that when we get the reports and see.
Right, and that's something, again, it's practice style and comparison of notes about service delivery.
Yeah, the only thing I was just trying to, these analyses are super helpful. I just wondered, to the extent that we look at it, ceteris paribus, like if is there a subgroup effect, that's the only thing, do we control, have there been the analyses when they do the control for age and all these other types of variables that are existing in the claims data, do we still see the effects? That's the only question I'd have is when we look at the graphics, are they ceteris paribus holding the other variables?
That's a great question and one I'd be very interested in exploring. But that was not that analysis.
What about the two procedures, upper and lower, same day? Don't look at each other.
No,
you got a patient that's anemic. You found out in your office that it's probably not just colon.
Yeah,
you want to look at both ends.
I'll be honest with you, we have not put that in the analysis. My guess would be the upper would be not part of the episode as structured. Now, I will say there are people who have looked at practice standards, and that, there are some places that do a lot of them as opposed to more selective. On the other hand, I do not believe we have built any of that into this episode, so the double procedure probably would not be part of this episode.
Cross.
So what?
At Blue Cross, we have policies in place to where it's a bundle, like those two procedures will get bundled for payment when it's an upper and lower GI together.
Well, I know it's half.
Within a certain period of time.
The reimbursement's half. What it would be if I brought the patient back tomorrow.
And I think our policies are within a 15-day window of each other.
Brought them back in 2 weeks.
And
or 3 weeks.
And with
because
this,
that happens, doesn't it?
Right. Well, and that we're actually today I assigned one of my analysts to look into that. With this episode, the way we're starting to analyze these services more thoroughly, we're going to look into that upper and GI to see if there is a quality issue going on, a utilization issue going on that could be driving these costs as well. So this is a point that we are starting to look into.
It's really inappropriate to have a patient that comes in with iron deficiency anemia not undergo both an upper endoscopy and a colonoscopy. However, your organization has disincentivized people financially from doing that, and it's only due to the really ethics of providers and our commitment to our patients that we wouldn't put them through double the anesthesia, double the number of times having to come in, double the inconvenience, but you ought to really look at that. In fact, I think you should be rewarding people from doing both procedures the same day rather.
Thank you for that feedback.